We shall now go on to our next speaker, Dr. EKTA RISHI, who is going to show a series of wonderful videos. She was a senior consultant doing extremely well in the Shankar Netralaya, and then she moved on and and from the way her videos are, I can imagine that she is doing phenomenally well where she is. An exemplary surgeon, and she's going to show us a range of videos to drive home a point of, again, past planar vitrectomy. On to you, Dr. EKTA.
Hello, EKTA. Hi.
Can you share your video, or should we share it? No, yeah, she's in
the US, no?
Yeah. EKTA, you unmuted?
Okay. A big hello to all, and thank you, Dr. Chitra and ARC, for the opportunity today. And it's a pleasure always to be on this platform. I hope you're able to see my screen.
Yes.
No.
It's dark, but I think, yeah,
Right.
she's got the video. You start.
Start.
Right. So basically, I'm just presenting 4 cases which are of traumatic zonular dialysis. And the difficulty of zonular dialysis is increasing from case 1 to case 4. The first case is with an iridia. The second case goes on to a higher level of zonular dialysis. The third case goes on with a more higher zonular dialysis. And the fourth case is with iridodialysis as well.
Zonular dialysis management in traumatic cataract. Case 1. It's a 2 clock hour dialysis with an iridia after capsulorhexis and phacoemulsification. Think about an iridia lens with placement in the bag and a good pars plana vitrectomy to look for cortical segments which have flowed through the zonular dialysis. The case 2 has scattered sparse zonules with a relatively centered lens and a lot of iris damage. After rhexis and phacoemulsification. An IOL can be placed in the bag along with an iridia CTR in the bag. Post-operatively, it gives good result. Case 3 has 6 clock hours of inferior zonular dialysis. Rhexis is a bit challenging. So is the phacoemulsification. Use iris hooks for a good visualization. Making a scleral groove and using straight 10-0 proline needle to fixate a Sioni ring. The suture is passed through the Sioni hook and the CTR is placed in the bag. This is the second pass and it is fixated to the sclera. A foldable IOL is placed in the bag. Again, a limited pars plana vitrectomy and a good fundus view helps this patient. Case 4 is a traumatic zonular dialysis along with iridodialysis. A scleral groove is made, limited pars plana vitrectomy, and 10-0 proline is used with a straight needle to do the iridodialysis repair with McKennell sutures. Iridodialysis repair shows that the lens looks pretty centered now, and the anterior collapse of the form vitreous was tilting the lens. Pars plana vitrectomy is a better choice in such patients. The lens was managed with aspiration. Always think about iridodialysis repair in the same sitting. Thank you.
Amazingly wonderful videos, Dr. Ekta. Each has a teaching pearl with it. But for the sake of discussion, to bring a lot more from the wonderful video, I have a series of questions which I would want Dr. Manisha, Dr. Malay, Dr. Agarwal, and Mohan Rajan to comment on. My first thing was in your first case, I would, Mr. Sunil, could somebody else,
Sound is there, no?
please everybody mute yourself. So Dr. Cyrus, we are able to hear you. Dr. Cyrus, could you mute yourself? Somebody has to call Cyrus, I think.
I'll call.
Yeah. The first thing I felt was the first case, CTR could have been. Mr. Sunil, could you tell Dr. Cyrus to mute himself?
Can
Where
we
is the
admin, please
admin? Admin can mute him.
Can mute him. Admin can mute him, please.
Please
Sunil,
mute
can you mute him?
Because you're. Yeah. He's muting it.
He's not.
No pressure.
Is not caught on.
Hello, can you all hear me?
Yeah,
Yes. You have to not hear you. You have to mute yourself. Yes. Thank you. So the first case was that if a CTR had been placed, probably she could have avoided some cortical, some stuff going into the vitreous, because from that small area of zonular weakness, it's just my thought, could the CTR have been placed earlier on? The second question I have is, such a large aniridia IOL, you need a very large incision, no, to place these lenses. But then could you have placed these aniridia segments and then place the IOL? And again, when you place the aniridia CTR in one CTR, if you place, does it not make sense to place another CTR also on the other side to have a proper stabilization of the capsular bag? These are some of the things. And the third case, my question was, instead of using a Sioni ring, it was a small area of dialysis. We could have done easily managed with a CTS2. What are the challenges in each of these? Could you, Mohan?
Yeah.
Manisha,
I think Ekta, all the videos were really fantastic, incredible stuff. I will tell you. I have see the first case has been managed very well. I would agree with you, because the aniridia lens itself was, because it's a very localized 1 or 2 clock hours dialysis, if I'm right. The fourth case, no. The fourth case is something I will do differently, because you have the hydrodialysis there, huge hydrodialysis, and you have got a mature cataract also. What I do is, normally I put iris hooks and retract that iris to the periphery. Okay, yes. I keep that in the periphery, in the angle. Okay, then I go ahead with the cataract surgery. But during the, if you do the hydrodialysis repair, sometimes you can rupture the anterior capsule. Of course, you are a fantastic surgeon, but I'm just telling you, for an average surgeon, they can even touch the capsule and the whole thing can go for a 6 after that, and the whole battle is lost. So what I would do is, I will do the, retract the iris with the iris hooks, keep it in the periphery, take off, manage the cataract, put an IOL, and then I will do the repair, the same fashion as what you did. Yeah.
Yeah. Dr. Manisha, you have anything to add?
Yes, ma'am, really beautifully operated. What would be the ideal choice of IOL in these patients? Plus, we get
can we look at
we have a series of patients, young patients who come with very weak zonules or absent zonules in Marfan syndrome cases. So they're young patients and they sometimes develop cataract early. They also require surgeries. In them, we are trying to use similar manipulations. So what would you recommend as the ideal intraocular lens for these patients?
Thank you so much for all your comments. And the first thing is I will like to address is the Marfan syndrome cases, because these are the patients with abnormal zonules. The pathology is with the zonules. So the cases I've shown are all traumatic zonular dialysis. So they have other healthy zonules. But in Marfan's, I don't consider fixating these lenses because it's better to just remove them. Ultimately, they are going to fall down.
Yeah.
Correct.
100.
And they have a high chance of retinal detachment. So it's not an ideal condition to be fixating the IOLs and doing so much manipulation. Coming back to Dr. Chitra, the first case, because it was an old trauma, slightly older trauma, there was already fibrosis which had set in. So you could see a small area which was retracted. And there was a lot of aniridia as well. So even a CTR would not have helped because this was not moving at all. There was fibrosis, but there was an area which was open, and through that it just had to flow.
Yeah.
But maybe more viscode there would have helped, probably.
Yeah. And how do you take care of the pigments in the aniridia iode, or the safety of the pigments?
Right. So, yeah, we have been looking at this, but so far, so good, because we have not seen much of pigment dispersion and discoloration. And these are the lenses which we use from IOC. But they are relatively we didn't face much of glaucoma and pigment dispersion.
Sometimes they bleach. I have had a couple of patients who bleach over a period of time.
Right. But presently, the lenses which are coming are looking better than before. And I have some 7 to 8 years of follow-up on these patients, and we didn't see much of pigment dispersion, luckily. Because if we are going for Marshall lens and all, they are definitely more expensive, and people are not able to afford them better. The iris segment, same ways, if we are going for the soft silicon segments and we are stitching, again, the possibility of glaucoma is much higher with these patients. So it was much more easier here. Yes, if I would be having the CTR at that time, CTR would also have been an option for the first case, but I was not having it there. And aniridia IOL was already ordered for this, and it was working well for him. So that's the reason. Aniridia CTR, yes, agree. 2 CTRs are the ideal, but it becomes more heavy. So the manipulation really becomes more difficult as you have already an IOL inside, then you are putting another CTR. And ultimately, this was a patient who was not affording much, and it ultimately fibrosed and created something like an iris. So something helped. He was not affording another CTR. That's the reason. But yes, ideal situation would be to put 2 aniridia CTRs.
Absolutely.
Then the third thing was about the traumatic and iridodialysis.
No, CTS. Iridodialysis, I was going to ask anyway. Mohan told the alternative, which is what I wanted to be highlighted, that could have been done like the way he mentioned. But CTS against CONE, your thoughts?
Yeah, because I have probably more experience with CONE. So I've been in that position when I've been doing regularly these cases. So probably that's ultimately immediately available and you go ahead and do it off. So that's the reason. Because I work more with vitreoretinal surgeries. So I don't happen to, these are the things like you keep doing scleral fixation, and CONE fixation is not something very different from it.
Yes. No, wonderful videos, Ekta, really wonderful. And the very intelligent way of keeping a pars plana open so that, you are able to deal with the vitreous from behind and keep the posterior surface.
He also made sure every time she went into the posterior segment, had a look at the posterior segment, which is very important. And especially with Marfan syndrome, I also believe that a total vitrectomy, almost you do it off. Better, because high incidence of RD, because when you do a lensectomy, and not only an anterior vitrectomy, but to do a good vitrectomy. Yeah.
Thank you very much.
If you look at the zonular pathology, in
Yes.
cases of zonular pathology, be clear, like this is ultimately going to be progressive.
Yes. Yes. And better to
And
fixate.
Dr. Ekta,
Yeah.
up to what amount of zonular dialysis you will not use any support, like as Dr. Chitra was telling, that capsular supporting hooks you have not used. Don't you think it would have been more useful in stabilizing the capsule?
Yes, it would be, but sometimes even it tears off the capsule. So in my hands, I have not used it much. That's the reason that I don't usually go ahead with it, and I'm able to manage it because I have placed this CONE usually early in the stage. Most of the time when there is some cataract, that time you place these hooks and then you handle the lens matter later.
And up to what amount of dialysis would you still try to salvage the capsule? Because what happens, the people you must have seen, the entire capsular lens back goes down and people have removed it from the retina.
Right. So being a vitreoretinal surgeon, any amount of dialysis, I first give a try. And even if it falls down, I know ultimately I'm going to do the vitrectomy and I will remove it. But if I am able to fixate it well, I will still try to do that in a traumatic case.
I think the broad cutoff will be around 180 degree.
180.
If you have less than 180 degree, probably you can manage to a certain extent with a CONE or a segment or whatever it is. But beyond 180, then that's my cutoff, broad cutoff. There can be exceptions to the rule, but broad cutoff is beyond 180 degree, and I go ahead with the removal of the lens and scleral fixation. I do usually glued IOLs for these patients.
Dr. Rajan, my concern was in such subluxation, doing capsulotomy is very difficult.
Yes.
So,
and nowadays I use the femto platform, which makes life very, very easy for us. Fantastic. It is really.
If you don't have the femto platform,
for people like us.
no, you can initiate the rexus and then use capsule hooks to give stability and then move on to complete.
Something like a bimanual rexus you have to do.
Yeah.
Bimanual rexus using micro rexus forceps on either side, holding the capsule on one this thing and then tearing it with the micro rexus forceps.
The only thing will be to keep in mind is the more the zonular dialysis, the centration of the lens is going away. So from where you are starting the rexus and ultimately where your rexus will be, you'll have to figure it out.
Yeah.
That's why at the end of the thing, when you put the lens in the bag, then you need to probably, at that time, the rexus will be eccentric and you need to probably enlarge the rexus and make it centric at that time.
Exactly.
Yeah. Thank you very much, Dr. Ekta. Really nice to see you after a very long time.
Thank you so much.
Wonderful videos. It was a treat.
Ekta, say hi to Pukraj.
Yes.
Definitely. Thank you so much.
We miss you both.
You added color to our ARC webinar with the variety you brought in. And thank you.